Hello, my name is Nina Espinoza. Thank you for viewing my presentation on current and classical intervention theories. This is a brief overview of what we will be discussing in this presentation. We'll begin with my classical theory, which is existential therapy. This was born out of existentialism, which is a philosophical theory or approach which emphasizes the existence of the individual person as a free and responsible agent determining their own development through acts of the will. It spontaneously grew throughout Europe. Many different people from different places were having these same ideas around the same time. And World War II really pushed it further. And after World War II is when it grew to the United States. Viktor Frankl is one of the prominent figures who contributed to that growth of existential therapy. He had an MD in philosophy, and he was already studying existentialism and existential ideas prior to World War II. And in 1942, he was actually taken prisoner in camp during World War II, and this really strengthened his ideas and feelings about this theory. He the he developed a therapy called logotherapy, which is therapy through meaning. And one very important quote that he has said that very much resonates with me is the last of human freedoms is to choose one's attitude in any given set of circumstances. Rollo May was also a pioneer of existential therapy. And like Viktor Frankl, he studied a lot of Freud and Alfred Adler. And he also had a very harrowing experience after being infected with tuberculosis. And while he was in the healing process of that, he was studying a lot, reading books such as Kierkegaard, and he was very inspired. He began writing several books along the lines of existentialism, and one of them is the book, it's a very popular book called Existence, which was written in 1958. Now, this is a really great video I found describing dialectical behavior therapy, which is the current theory that I am going to be presenting on. So this video is just really great. I'm gonna go ahead and play it so we can learn a little bit about the creation of dialectical behavior therapy.
My name is Stephanie Vaughn, and I'm a clinical psychologist in Nashville, Tennessee. I am a dialectical behavior therapy Linehan board certified clinician, and I own a private practice in Nashville in which we conduct DBT as much as possible to fidelity on adolescents, adults, and families, in addition to other cognitive behavioral therapies. I founded and continue to run the Vanderbilt University's dialectical behavior therapy peer consult team and serve as a consultant to a variety of hospitals and schools. I am an affiliate professor of Vanderbilt psychiatry and an associate professor of Vanderbilt counseling program. DBT was originally founded in the late 1970s by Marsha Linehan, who was a suicide researcher at the time. She actually did not know anything about borderline personality disorder, but came to find out about it later. DBT is well known for treating borderline personality disorder. Linehan found that there was support for the use of dialectical behavior therapy with borderline personality disorder, but today it's almost a faux pas to suggest that DBT is only used to treat borderline personality disorder. In fact, it's been empirically validated for a variety of different populations and issues, including substance use disorders, suicide attempts, PTSD, self-harm, symptoms of depression and anxiety, eating disorders, that's including binge eating and bulimic tendencies. There is less evidence supporting anorexia. frequency, rate, and length of hospitalization have been shown to decrease repeatedly in different studies that have been conducted on DBT. And it's also been supported with not just adults, but with adolescents. Women are the primary gender in which DBT has been supported with, but there has also been some evidence that it's helpful with both genders. And so it's no longer associated just with borderline personality disorder in women. In the 70s, when Linehan first started working with suicidal individuals, she tells about how it was easier to get grant money because she was the only one who was doing randomized controlled trials with suicidal individuals. And what she would do is call the hospitals, and her research team would call the hospitals in the area and ask them to send her the most severely suicidal and self-injuring populations, and they would do so, and she would try to, as she says, cure them with behavioral therapy. But what she found was not only wasn't enough, but oftentimes it was extremely aversive to the patient, and they would quit treatment, they would get angry. In the 70s and 80s, behaviorism was popular, but also the humanistic approaches were also dominating at the time. And so she thought, well, maybe there's something to this humanistic approach. Behaviorism has a reputation for being fairly sterile and cut and dried. She was willing to take a step back and consider that this other approach, humanism, would be more appropriate stance. And so she tried it. And that didn't go well either. If we look at humanism or the humanistic approaches as being at one end of a continuum, and we look at behaviorism as being at the other end of a continuum, they're fairly opposite. And so she went from one treatment to another, almost in a black and white fashion, from one end of the continuum to another, and found that neither was effective. And so Linehan very much wanted to help this population. She had her own struggles with mental illness. She came out in the New York Times over the last few years and acknowledged that she had severe mental illness when she was in her late teens, and had a personal interest in helping all of the patients that she saw. And so she was dedicated to, as she would say, getting them out of hell. She felt like the population she was working with was in hell, and she wanted to be able to get them out any way that she could. So she wasn't particularly tied to a model of psychotherapy. When she was trying behaviorism, the patients would respond feeling like the therapist was saying that they were the problem. Behaviorism is the model of change. When she would give feedback about ways that they could change and improve their symptoms, they felt like she was saying that it was all their fault. So the response was, what are you saying? This is my fault? What about my employer? What about my kids? What about my spouse? What about the environment that I'm living in that makes it extremely difficult for me to get better? And in trying to figure out what works, she had her research team watch through a one-way mirror so they could see in, and Linehan and the patient couldn't see them. And they would take notes, and Linehan would just try to do what worked. So she would do a little of this and a little of that, and the team would take notes. And what they found was, certain things that she would say or do, the patient would get upset, and then other things seemed to be more regulating. What they found wasn't a third theory. It wasn't something totally different. It was more of a movement or a blend of the two. So instead of doing just behaviorism, instead of doing just humanism, we're moving back and forth between the two. But the fulcrum between the two, the thing that helped to balance those two seemingly opposite theories, was dialectics. The origins of the theory involve a non-pejorative stance. Instead of painting the patient as the problem or calling them manipulative, which is a typical pejorative term that's used with individuals with borderline personality disorder, the approach was one of equals between therapist and client. Her balance between CBT and humanism was also influenced by her Zen training. DBT was actually almost called Zen behavior therapy. Linehan is now a Zen master, and when she was training back then, she found that a lot of the principles she was learning in Zen and in her meditation were applicable to her population. and mindfulness being one of them. The key points are as follows. DBT was developed in the 1970s. Linehan had personal experience. DBT was the first psychotherapy to formally incorporate mindfulness. DBT is not just for borderline personality disorder or severe populations. DBT combines strategies from cognitive behavioral therapy and humanism. DBT balances CBT and humanism with dialectics. There is a heavy Zen influence in DBT.
All right, so like I said, that was a very great comprehensive explanation of dialectical behavior therapy. Now, as far as tenets and principles, starting with existential therapy, one of the most prominent components of existential therapy is self-awareness. The goal is to really encourage self-awareness and authenticity in the person. Also, freedom and the responsibility that comes along with that freedom. Finding purpose and meaning in life, anxiety, existential anxiety or angst, and the idea of death and coping with that idea and coming to terms with the fact. Principles of DBT is with DBT, there are 4 pillars, 4 modules of the therapy that are the main focus of DBT practice. It is change oriented. So within each of these modules, the client is given skills and techniques to develop each of these tenets. So they are core mindfulness, distress tolerance, emotional regulation, and interpersonal effectiveness. So we're going to do a quick Venn diagram compare and contrast of existential therapy in the blue and DBT in the red. So first, starting with existential therapy, it is unstructured. There is no techniques, there's no right or wrong way to do it. It's just a very unstructured therapy that you can kind of tailor to your client. With existential therapy, there is little consideration for the environment. They do practice, self-determination, not just in the sense that the client chooses what to do, but also in the sense that the client is expected to take responsibility for everything that has taken place in their life thus far. And in doing so, that leaves little consideration for the environmental effects and factors that may have contributed to their circumstance. It is very relational. Existential therapy focuses very much on the relationship of the therapist and the client, and it is very dialogue focused. Like I said, there's not structure or techniques. It's really just asking the right questions and having the right conversations. And again, it is a philosophical approach. With DBT, as I mentioned, it is a change-oriented practice. So it does have techniques unlike existential therapy. Again, those techniques are present. Also, it is a person and environment focus. They do, again, acknowledge the environment and the effects of social context. And again, it's behavioral, so it is focusing on that change and that behavior and how to improve. And it does have that Zen focus as well, as mentioned in the video. Now, some things they have in common is that self-reliance. Both of them do encourage self-determination in allowing the client to make the decision they feel is best and be experts of their own circumstance. They both do work well for people who are experiencing suicidal ideation or who are experiencing crisis. They do both work with the strengths perspective. And both of these theories work well in group and individual settings. Some goals of existential therapy, like I said earlier, it is increased awareness, just really being fully aware of yourself as a person, your choices and thoughts and beliefs, discovering the self limitations that the client might be putting on themselves, assuming responsibility for those thoughts and assuming responsibility for their decisions, and also expansion. It is a goal that they expand their thinking and that they just expand in their existential feelings. Goals of DBT therapy. Now, as I mentioned earlier, it is those 4 modules that they focus on building coping capacities, building strengths in those 4 modules. But there are also stages of dialectical behavior therapy. And the first stage is stabilizing and control. They're getting the client to stabilize into a not chaotic mode and also to control their behavior, because many of the people who do participate in dialectical behavior therapy are again those severe populations of borderline personality disorder, people experiencing self-harm and things like that. Although it is not limited to them, those are some of the people who do come in at that stage 1, and the first thing they need to do is stabilize and gain control. Stage 1 generally takes an entire year in dialectical behavior therapy. Once that is accomplished, they move to stage 2, which is addressing any past trauma that may have contributed to the circumstance that they're in now and to their mental illness. Stage 3 is building that self-esteem and also learning skills and techniques to cope with daily living and daily stressors. And stage 4 is just optimizing that coping capacity and optimizing their quality of life. So now the significance of existential therapy is the most prominent thing in existential therapy is that provider client resonance. As I mentioned, the most important thing in existential therapy is that relationship between the therapist and the client, because again, they don't have techniques. So that relationship is the most important thing. And the provider must really lead by example and experience in this practice. It really does help if the therapist has already gone through these stages in their own life, as far as with their existential questioning themselves, like Snoopy there in the corner, where am I going? What am I doing? What is the purpose of life? So if the therapist has already experienced that, then it's definitely going to help them in providing services to their client. And it also helps because, again, with existential therapy, it is often the result of somebody experiencing a crisis in their life, whether, it was an accident or if they lost somebody very close to them. If the therapist experienced something similar, then that's definitely going to help with that provider-client resonance. Now, self-determination, again, this is not something that is exclusive to existential therapy, but what is unique about it in existential therapy is that part where not only are they encouraged to make their own choices and do what's best for them, but also they are encouraged to take accountability and responsibility for designing their life thus far, which again does not take into account the social context or the environmental factors. Another significant component of existential therapy is that there is an emphasis on being rather than doing. So again, that ties into, the lack of technique. It's not about doing, this in a cookie cutter manner. It's just really about being and experiencing and existing. Rational emotive therapy, gestalt therapy, person-centered therapy, focusing therapy are all forms of existential therapy. Now, significant things about dialectical behavior therapy, I think first and foremost is the growth that it has taken from its original application, which was being applied specifically to people with borderline personality disorder or with self-harming impulsive behaviors. And since then, as mentioned in the video, it has grown to eating disorders and depression and anxiety, and just a lot of other situations have been proven to improve with the practice of dialectical behavior therapy. I also think it's very amazing that it was created by, I didn't know the best term to use for it. I didn't want to call her a victim or somebody suffering, so I'm calling her a survivor of borderline personality disorder. Because if you know about borderline personality disorder, it actually has a very high rate of death. Many people with borderline personality disorder do die oftentimes by their own hand. So I think it's very amazing that somebody who experienced that mental illness herself is the one who created something that has been so successful in treating it. Another very significant component of dialectical behavior therapy is that relationship as well, like in existential therapy, the relationship with the client. But in dialectical behavior therapy, working with people who are experiencing these kinds of disorders or mental illnesses, one thing that they genuinely need is validation and acceptance. And the key thing in dialectical behavior therapy is to provide your client with that validation and acceptance while still encouraging change and not making them feel invalidated or unaccepted. So that's a real skill of DBT. And then it's also very significant that it is known as the most effective treatment for self-harming and impulsive behaviors. So when we talk about strengths and limitations, starting with existential therapy, one strength about it is that it is a very creative method. Again, I keep repeating it, with the lack of techniques, it does leave a lot of room for the therapist to really tailor the service to the client. They can pull intervention methods and techniques from any other modality and tailor it to their client in an existential perspective. I also think it's very much a strength that they do utilize the strengths perspective. Another strength of existential therapy is that it is very much a catalyst. Oftentimes, it is a catalyst for a person kind of just reaching a new level in their life, reaching a new level in their existence, overcoming maybe something that they were dealing with, and just really gaining a good understanding of life and themselves. And it is a multicultural method. It can apply in a multicultural setting because these types of feelings are universal in any culture and anywhere in the world. People are having questions about their purpose in life, about the meaning of life, and having that existential anxiety. So limitations are, again, the lack of techniques. That is something that is a struggle because oftentimes when clients decide to come into therapy, they are looking for the therapist to give them something to do. They're looking to walk into a place and say, this is wrong with me. And the therapist will say, okay, do this, this, and this. And that is not something that happens in existential therapy. And again, that self-determination aspect where they do ignore the social context and the environmental factors. There's also little empirical evidence. It's hard to quantify the success of existential therapy. And although it is a multicultural practice and that was a strength, it is also a limitation, again, because of the ignoring of the environmental factors. Oftentimes, people who have experienced oppression or racism are not being validated in this method because they are being encouraged to take responsibility for their circumstance, regardless if it was created by an oppressive situation or if it was their own doing. Some strengths of dialectical behavior therapy is that it is highly effective. It is very, very structured. So, it's very valid techniques, things that people can actually do and practice. And it is applicable to many disorders and mental illnesses. Some limitations is also the structure. This seems to be a limitation in my research just simply because the providers have to go through so much training in order to even be able to provide dialectical behavior therapy, which I don't necessarily see as a bad thing. I think it's good that they have to receive so much education. But again, in my research, it was mentioned as a limitation. Also, it is difficult to implement in a community intervention, which seems like not too bad of a problem to have. If it's working really great on a micro level, they want to apply it to a more meso and macro level. And this is something that is newly in the works, and so it's difficult to implement as of now. But I think with more practice and research, that they will find a way to apply this to entire communities. And also the client commitment. Many of the people who do go to dialectical behavior therapy again are experiencing some pretty intense issues. And so when you look at the fact they have to do individual therapy once a week at least, group therapy, and they're committing to this therapy for at least a year, often more, because that's just the first stage is 1 year. So getting the client to commit to that entire practice tends to be a little bit difficult. And these are my references. Thank you again so very much for watching my presentation, and please feel free to reach out if you have any questions.